Good evening, ladies and gentlemen who have joined us on this Dr. Fundi channel through Facebook, YouTube, Instagram, and also via the Dr. Fundi website. We have an interesting interview or conversation in prospect. Today we are having a phase 2 of discussion on the state of mental health services in South Africa. I'm saying phase 2 because about 2 weeks ago we hosted Mr. Mark Haywood, who used to be at Section 27 and was involved on the issues of life esidimeni tragedy. And so we spoke to him about the state of mental health services in South Africa. Today, we have a special guest, Dr. Mvuyiso Talatala. Now, Dr. Mvuyiso Talatala, originally from Ndabankulu in the Eastern Cape. So he's my homie. Right, so he's a specialist psychiatrist who's in private practice. He practices at Lisedi Private Hospital in Diepkloof, Soweto. Now, a little bit about him. He went to the same high school that I went to, that is St. John's College in Umtata. That's where he completed his matric in 1991. He went then to medical school at the University of Natal. It was called University of Natal those days. It's now called UKZN, Nelson Mandela School of Medicine. He did his undergraduate MPhD degree there, and he qualified as a medical doctor in 1997. So he did not waste any year there. He did it in record time. Other guys, they add a couple of years to what is supposed to be a 6-year degree. And he's been a specialist psychiatrist, I think since 2005, but you'll correct me if I'm mistaken. And so that would make him to be somebody with about 16 years of experience as a psychiatrist. Now, other interesting, information about him is that he has had a stint as a lecturer at Wits University Psychiatry Department based at Chris Hani Baragwanath Hospital. Also, he has participated in the organization of psychiatrists called SASOP, South African Society of Psychiatrists. He's a previous chair of the SASOP. He's also been a member of the advisory committee of SASOP on African psychiatry. Now that's of interest to me, the area of transcultural, psychiatry. But also, he's done other things as well. He's also been, or is still a chair of the South African Mental Health Alliance. You'll correct me if you're no longer one. And also, he was one of the experts, that were invited as an expert witness at the Life Esidimeni Arbitration Commission under retired Judge Dikgang Moseneke. All right, so we have basically Umbondo Sanjiwe. We've got an expert, a very experienced, psychiatrist who is our guest today. And we just want to, take a dipstick and look at how are the mental health services in South Africa. With his 16 years of experience as a psychiatrist, practicing psychiatrist in private practice, but also in other areas as well, we think he will share some insights with us that will help us to better understand issues of access to mental health services in South Africa, issues of quality of mental health services in South Africa, issues of resourcing of mental health services in South Africa. Mhlekazi, Dr. Mvuyiso Talatala, welcome to the Dr. Fundi channel.
Thank you. I'm going to call it Dr. Fundi because it's Dr. Fundi channel. Thanks for inviting me. And you got me. I could not say no, even though it's a Saturday, because if you've gone to St. John's College, Iqala.
Exactly.
So to me, you would have been equal. So I could not just refuse. Last weekend, I was not. I was in a wedding, but this weekend I said no. Let's do it. And also, I think it's an important discussion, especially when you look at the state of mental health in South Africa. Just a few corrections, although I would have preferred not to correct this one because then it makes me older. I've been in Soweto from 2005, but I qualified in 2003.
Oh,
but
okay.
yes, yeah, which is not good for my age. But everything else is correct, and I am still part of the department at VETS, but as an honorary lecturer now.
Beautiful, beautiful. So you are actually part of, producing a pipeline of other psychiatrists, because we will talk about it, the number of psychiatrists in South Africa, the ratio, or the ideal number that a country should be having. So we'll talk about those things because those are the issues. I want us to look at issues at a systemic level rather than just focusing.
But just one point, I want to tell the people who participate in this discussion, brother, I'm impressed by you because you didn't ask me for my CV. So everything that you've said, it's not that I provided you with it. So you know me very well. Thank you.
Thank you. No. It's important. If I'm going to take your private family time, the least I can do is to at least, do enough preparation so that I show that, I respect your time.
Thank you.
All right, let's get on into our discussion, Doc. So you've been a psychiatrist now for how long then?
Oh, I stopped counting, but since 2003, that must be 17 years at least.
Yeah.
It was October 2003, so it's 17 years. But in private practice since 2005.
And I mean, when most of us were at medical school, and you were taken through the block of psychiatry at King George Hospital and other, was it King George and another hospital, there in Durban. It's one of the rotations that, you felt, I just want to pass it, but I'm not sure if I want to come back and specialize in it. So I want to know from you, when you were at medical school, did you know that you want to be a specialist in psychiatry?
I didn't think that I was going to specialize. I must also be honest. Looking at our backgrounds, I thought I'd qualify and I would work in the Eastern Cape. Maybe I'll end up opening a practice and look after my family. But I did take psychiatry quite seriously. Those were with me at medical school. They know that 1 year I was even a driver. We used to have at our time, we used to rotate at King Edward, King George, which is now called King Dinizulu, and Eddington. So I would drop people at King George and then go to I think it was Afanale, and then go to Eddington. So I did take it psychiatry seriously, and I did enjoy the material, especially the text of psychiatry. I must say, even if I'm gloating about psychiatry, I think psychiatry textbooks are written better than any other specialty. You don't struggle to understand psychiatry from its textbooks. So I did enjoy the material itself. And when I worked, I actually...
Now, before that, Doc, so if you enjoyed it, I'm also assuming then that the results, out of the many disciplines that you wrote, it must have been one of those where you did very well.
I did have a big range of marks. My marks, I won't mention them, but they were concentrated around the same area. But I recently, because I'm studying something else, I won't tell you what I'm studying because you'll then watch my results. We'll watch my results. No, we'll wait for the results. So I had to submit my the marks that you've got from your previous university. I looked at them. I should have done surgery. My top marks were surgery, actually. The range is probably up within 5% range. But my top marks were surgery. I was surprised by that. I don't think I've ever paid attention to that. So it means I understood surgery better, but I didn't have an interest in it, probably.
Yes, all right. So you did your internship where?
In Livingston Hospital in Port Elizabeth.
All right, and then your ComServe, was there ComServe already at the time?
Yes, I think we're the first group. To do ComServe. I did my ComServe in Mount Elif. Mount Elif is not far from Tabankulu.
Not far from Tabankulu, yeah?
Yes. Sorry, I'll mention just one joke. I'm sure it's the last joke for the evening. The only problem that I have now, we as a family will have functions in Mount Elif because my uncle is there. We still have functions in Tabankulu. I still get embarrassed when women now who are older, they're my age now, at old, they tell me, oh, you made me, you delivered my baby, you delivered my baby. And they're saying this publicly in a function. It's supposed to be confidential in terms of medical practices and ethics.
Yes, no, you know, it tells us how many times you've rotated, you know, around the sun. There's a number of Christmases that you've eaten or that you've enjoyed.
Yes, absolutely.
So you did your internship, you did your ComServe, you know, closer home. Did you just become an MO or you went straight to become a reg?
I'm one of those bad ones who went straight to become registrars. But part of that, which is not related to our discussions, and I'm not criticizing anyone, is that actually there was no job security for us when we finished our community service. It was not like I could stay in Mount Elif. Some of my colleagues did, but they were not paid. So I then realized towards the end of the year that I have to make a plan if I need to have a job, and I could not afford not to have a job. So I then applied in Durban to go and do psychiatry.
Yes. All right. No, lovely, lovely, Doc. All right. And then you did your psychiatry in Durban. Other people, they get MMed and then proceed to do the fellowship. Others will just end with MMed. Did you do both?
I ended up with both. It's politics of South Africa. Remember, back in the days, some universities will just do the fellowship of the College of Psychiatrists. Other universities will do the masters from their universities. Durban, at the time, was encouraging the fellowship, which is the fellowship of the College of Psychiatrists. But I also wanted to do some research. So out of my own interest, I then did the MMed as well. I did not finish both of them at the same time. So I did my study. I passed the college 2 and 3. I had done my study, collected my data, started writing. Then I passed and I moved to Joburg. Then I thought, do I need to complete this thing? Maybe I don't need it. Maybe I should stop. But then later on, then I thought, hey, what a wasted energy. Let me write it up and complete it. So I then did complete the masters. I only completed it in, I think, around 2009 or 2008 or 09, somewhere there. The university mustn't beat me. I can't remember the year. Sorry, it was on cannabis use in psychiatric inpatients. It was a study actually where we looked. I wanted to show that compared to the medical patients, like patients admitted with general medical conditions by the physicians, the cannabis used there will be less than in the psychiatric patients in our psychiatric ward at King Edward Hospital. So that was the study, and it confirmed that hypothesis.
Beautiful, beautiful, Doc. All right, now you've been around, you know, as a psychiatrist for say 17, 18 years. Now let's look at the state of, you know, mental health care services in South Africa. If you had to rate it out of 10, what would you give it?
What if I still need the job at Bara, full-time job?
No, we're talking in general now as a country. You know, don't talk about Bara specifically.
But the minister may still need to hire me. And of course, too many, I've been fighting too much, life is demanding, everything else. You know, I'm not going to give it a figure because that would mean I'm comparing it with others and I've scrutinized it. And at my level, I can't just say that.
Okay.
But I can definitely say it is not good.
Yes.
And you can weigh it how bad it is. Yes. And except on paper, I don't think we have moved much to what we had before 1994.
Yeah.
So pre-1994, we have not moved much in terms of, and I'll explain this later on. But if I can put it broadly, we still have a hospice-centric approach. By that, let me be simpler. We still are focusing on treating the most severely ill patients in hospitals. But remember, even if you have to take schizophrenia, which does have a worse outcome in terms of mental illness, it only affects 1% of the population.
Yes.
So that means if we're focusing on those kind of patients, obviously they're the most difficult to treat, they're the most costly to treat, but we are leaving out a lot of people in the population who are having common mental illnesses, anxiety, substance abuse, and others. So what I'm trying to say is that our design, and I can, as you ask questions, I'll explain this even further.
Yeah.
Our design of the system, not on paper. On paper, it looks better. We've done better in terms of policy, but in terms of what we have on the ground, we still have Stekfontein, Town Hill, Fort Napier, or Falkenberg in Cape Town as the big source of income. If I were to add, even if you look at the private sector, where you think that things would have been done differently, the way the law is written, it automatically makes it that the funding by the medical aids the schemes will only fund someone with severe mental illness in hospital. That's a good budget. Otherwise, if you've got any other illness that needs to be treated in the community, that is poorly funded. So overall, I would say we are still as bad as we were before 1994 in terms of practical terms.
So what you're saying to me is that whether we're looking at the public health, side of things in relation to mental health, or we're looking even in the private, there are serious, challenges of, resourcing and delivery of services. I mean, I'm aware that medical aid would pay up to 21 days for inpatient, but that is once a year. Beyond that, then you have to make a plan. And then if you also look at psychology, clinical psychology type of services, from medical aid benefits, they are very, very thin, So the funding, both from a private and a public point of view, is a challenge. So that's one thing that we're highlighting now already, that funding, but let's look at, as a country, how much are we spending, in percentage terms, in terms of the total cake for the annual healthcare budget? What are we spending, and what should we be spending when it comes to mental health care services?
I'm not a money person, so I'm quoting other people. But 2016, 2017, and I don't think it has changed now, South Africa spent less than 5% of the health budget. And that varied from province to province. Other provinces, I think Western Cape may have gone to 7%. I'm sorry if I'm quoting a wrong one, if I'm giving the credit. Other provinces will even be lower than that. But the average in South Africa, in terms of health budget, spent only less than 5% went to mental health care. And experts have said that maybe we should be spending around 10% of the health budget. I wouldn't be able to motivate with science why. Obviously I'm not in that space, but what people have done, and people, the economists, and
health economists,
yes, they've recommended that we should be spending around 10% of the health budget on mental health care.
Yes. Now, so that's the current situation. Can we just look back? You said there hasn't been much change since 1994. Can we just look at pre-1994? Because when I was, training as a medical student, that was pre-1994. I qualified in 1989. The state of mental health care service, especially for Black patients, wasn't great. Even the hospital we're talking about now, King George, it was a very, very old hospital. The facilities there were really, really, archaic, and so the issue, therefore, of underfunding of mental health services predates the New South Africa. But then one would have hoped then that once we were in charge, the new democracy, things would maybe improve in terms of prioritizing, mental health services, so that the legacy issues from apartheid days could actually be addressed. But you've just mentioned that things have not changed much from around 1994 to date, which is in about 27 years. Now, you were a president of SASO. Plus minus, how many psychiatrists do we have in this country?
Yes, yes. I'm going to address that. I was just going to, on the comment that you made about pre-1994, although I said from 1994, I mean pre-1994, actually.
Okay.
Nothing has changed to that. And in fact, if I were to be a bit difficult at the risk of me getting a job at Bara, not getting a job at Bara, is that what we have just done is that, if you know Town Hill in Pietermaritzburg, we've just replaced the white patients that were at Town Hill with black patients.
Yeah.
But we still have the same Town Hill. So the budget remains the same. But otherwise, maybe things have got slightly better for the black patients because they never used to access Town Hill. But otherwise, we still have the same Town Hill. We have not developed services better in the communities of Pietermaritzburg, for instance. As an example, I mean, it's the same throughout the country. In terms of psychiatrists, I always debated with my psychiatrists with my secretary when I was the president on a month-to-month basis as to exactly how many psychiatrists we have. I can say today it's around 600, but it fluctuates, and I'll tell you why it fluctuates. Firstly, people pass. So every year we've got 20 to 40 people come joining the system. But also, which shocked me, people emigrate. Yes. You'll be surprised by how many people emigrated last year. I think we've got over 20 psychiatrists that emigrated in the past year. Yeah. Almost probably equivalent to the number of people qualified, because last year we didn't have the 2 exams because of the COVID. So we only had 1 exam. I didn't check how many people passed, but usually pass between 20 and 40 people per year. So if you've got over 20 people immigrating, it means we'll still at the same number. So we've got about 600 psychiatrists in the country.
Now, obviously, you know, we are a country of plus minus 60 million people. Now, if you are saying we've got plus minus 600 for about 60 million people, that to me says the ratio of a psychiatrist to, you know, the people who need the services of psychiatrists in the general population. I think that ratio is not so great. And if we are bleeding psychiatrists because they are emigrating, then it means that the problems are likely to be, you know, more in terms of access to that specialist type of care.
Absolutely, absolutely. I'm going to give you an experiment, and I'm going to ask you to phone my office tomorrow on Monday and ask to make an appointment. You're going to struggle to get an appointment. That is how the shortage is, because the number of psychiatrists, even in private sector, is the ratio is too low for the population. Remember, the private sector population should not be that big because not many people have got
about
medical aids.
17% of the population.
Yes, no, psychiatrists have no business problems. They can't complain that they don't have patients in private sector, despite the limited funding. So sometimes say that it is so bad that despite the limited funding in private sector for psychiatry, and despite the shortage, and despite the less number of people who can afford private healthcare, but psychiatrists are still busy in private sector. You can imagine what it is in public sector. In the public sector, it's the ratio is so bad, because I think about 300 psychiatrists out of the 600 are in full-time private practice. Probably around 150 are contributing to the public service, and the other around 100 are in between, or 150 are in between the two, or retired, or whatever they are. So you can imagine how bad things are in the public service in terms of the ratios. Just to be bad to my patients, I sometimes think in my head, when my patients are demanding reports and everything, that I can't wait for NHI to come in, because we will be so overwhelmed, we won't have time, and not the patients, the employers won't have time for employers who are demanding this and that from the psychiatrists, because the need is so much, we will never cope.
Yes. In fact, what you've just spoken about now, that's the space I operate in. You know, my company is one of the health risk management companies that advises employers, especially on issues around long-term incapacity and also, you know, ill health retirement applications.
So when you're demanding a report,
it's always a struggle to get an appointment, you know, for a person to have a second opinion medical with you guys. And it's also a struggle to get you guys to give us the report, because we also have got turnaround times that we need to meet so that we can be able to advise the employer that this person, you know, is totally and permanently, you know, occupationally disabled, he's been on treatment, optimal treatment, psychotherapy, pharmacotherapy, 24 months, there hasn't been much improvement. Maybe you should consider them, you know, as permanently disabled. But, you know, it takes so long to get those appointments. So I'm actually confirming what you are saying, that getting appointments with psychiatrists, and this is throughout the country, it's actually one of those very, very difficult things.
It actually look upset, because you'll say, but we're paying these people, we're going to pay you for this report. I also say, I'm being paid. I even tell my nurses in the ward that I should not be complaining about this work, because I'm being paid for it. Apart from loving it, I'm being paid for it. But the shortage is such that the demand on us is beyond our ability to meet it. We can't. I don't think we're keeping up.
Well, whilst I have you here as my guest, maybe let me also just say one thing from the same space, that at times, you know, as the health risk managers who have to advise employers, we sometimes get frustrated when it comes to temporary incapacity leave, because there is a tendency by your colleagues to actually book a person for the whole year, you know, and that becomes a problem, because we need to know every month or every 3 months, you know, what is the progress. So when somebody is booked for the whole year, you know, then it is difficult for us to actually make a recommendation on to whether that person should be granted the benefit, you know, for temporary incapacity leave or not. But anyway,
I know what digressing, but let me comment on it. It's actually, I would not support it, actually, if it's a good thing that you are raising it. You know, the longer you are off work, the less likely you'll be able to go back to work. So it is important that we encourage people to go back to work. So if we automatically book a patient, I know patients sometimes demand it, they want to be booked off immediately for 2 years or forever. But remember, even with mental illness, we want to treat you, it's part of your quality of life, that we can treat you and get you back to your normal functioning before you got the illness. So it's important that we get there. But so those errors happen, but we shouldn't be encouraging people being put off, or unless it's an extraordinary situation that stands out, that there's nothing that can be done here. It was a head injury with many things, you know.
Yes. All right, now let's leave that one. You know, I was just being opportunistic to say there is that situation. Now, in an ideal world, you know, when you talk about, you know, a mental health, you know, professional team, who should be part of that team? In an ideal environment, you know, I mean, there are a number of professions that should be part of a holistic kind of team, you know, to manage patients. You know, if we were in a first world, who should be part of that?
Even in our world, we should have this because we are training these professionals. Yes. I mean, the psychiatrists should be there. We call it the multidisciplinary team. Some people call it the multi-professional team, but it's composed of a psychiatrist, a psychologist, clinical or counseling psychologist, an occupational therapist, physiotherapist, a social worker, and a dietitian. You may think that we don't need the dietitians, but we actually do need them. I think that's the core part of the team. But obviously, with other illnesses, you may need an educational psychologist. So you may there's a general practitioner. It's quite important as well with other illnesses.
Yes. So in your, you know, almost 18 years of practice, you know, have you had that full complement, you know, of professionals working with you, you know, when you have to look after patients, especially now in hospital settings?
In a tertiary environment, like I ran a ward at Stekfontein Hospital on a part-time basis from 2006 to 2013. In a hospital environment, like Stekfontein Hospital or Tara, you will have sort of, you may not have the dietitian. In fact, at Stekfontein at some stage, I even had a speech therapist. So in a tertiary environment, specialized, exclusive in Gauteng, you may have that. In private sector, you do potentially have it, but it's not funded. So the professionals are there, but it's not funded. So you never actually work in the team. So in private sector, you sort of work alone. The design of the system that doesn't encourage us to work as a team. So if to summarize, in the state, it can be there, but it's in Johannesburg, Pretoria, Cape Town, and Durban, and Bloemfontein, and a little bit in Port
Definitely
Elizabeth.
not the Eastern Cape.
No, not in Tabangulu. So in private sector, it's theoretically there, but it's not funded. So it doesn't exist anyway.
Yes. Now, Doc, so basically what we are zooming into now is, the shortage of the relevant professionals. We talked about the psychiatrists. We're now talking also about, relative shortage in terms of the other members of a multidisciplinary team, except in tertiary centers and more urban areas. Now, in terms of production or more production of these professionals, here I'm talking about psychiatrists because that's the space, do you think there is a possibility that there could be increased outputs of psychiatrists now? That is, obviously, that would mean increased intake by the universities, but also maybe sensitizing the undergrad students to actually choose psychiatry as a profession. So is there an opportunity, before we also now go look at importing psychiatrists from Cuba?
I hope we'll not. No, there is a possibility to increase, and I think we should advocate for that. But there's a few limitations to increasing. It's not us failing. I know my younger colleagues will think that we are running a boys' club. That the specialist would limit anyone from joining the profession. There's that criticism as well for the College of Medicine. But apart from that, there's limitations, there's budgetary limitations in the terms of how many registrars are doctors who are training, how many, they get what's called an N number allocated, so that, let's put it simpler, a post. How many posts can universities have to train doctors who have chosen? We're talking about now the ones who have chosen to do psychiatrists. How many can government afford to train? Because remember, the government is paying for this training, whether it's in the form of salaries or it's in the form of making sure that the facilities for training are there. So the government, how many can the government afford? So there's limitation in that, because government doesn't give these posts with ease. Then there's the other limitation is that how many people then will have an interest in actually doing psychiatry itself. So where we then have to encourage their colleagues. I think the other one, elephant in the room that we have not dealt with, but maybe it's being dealt with now, is that we have actually not increased our medical schools. So we have not increased the number of people who are being trained to be doctors, irrespective of what they're going to be. In fact, I always mention this, that you can say, for instance, Black doctors don't want to specialize in psychiatry. I'm just saying that as an example. But if you are only training so few, there's so many other interests people will have. You then, if the likelihood is that in any country only 10% of doctors who qualify will want to do psychiatry, but if you've got so few qualifying, then you're going to have so few wanting to do psychiatry. So there's limitations at various levels. I must also say that, unfortunately, it's also a specialist, it's a master's level training. So there's also a limitation. It is quite demanding to specialize in any discipline, including psychiatry.
Okay, all right. So basically, there are challenges with regards to now, increasing the outputs, and those are challenges that can easily be corrected because they require financial resources in a country now that obviously at this point, with COVID-19, almost every department is now forced to reduce their budgets because as a country, we are not doing well. So that is the challenge. This week I saw a new intake or an intake of new students to the Nelson Mandela University, the medical faculty that was supposed to have been started by our late colleague, Prof. Pepeta, and hopefully in the near future, then there would be more people that will be taken in from that facility, although I'm also hearing other things that there are those who would want WSU, and medical school and the NMU to actually be one thing. But anyway, this is just rumors. So it may be a new medical school, but there are others who are actually saying, why don't you just combine them and make them one? Which means the numbers would then end up being the same. But anyway, that's not what we are here to talk about today.
Don't get us into Eastern Cape politics.
Yes. But anyway, Doc, so we've looked at the number of psychiatrists, the ratio that does not look so great. The net effect of all of this is reduced access to, mental health care services, whether we're talking private or we're talking public. Now, you are quoted in one of the articles that I read. It's called the Fourways review that came out on the 24th of October last year. You are quoted as saying, mental health care services in South Africa are reactive. You also quoted as saying, we are very good in terms of policy, but we are poor in terms of implementation and financial investments. Would you want to add more to what you've just said there?
Hey, journalists are silly, man. I don't even know the paper.
Yes.
that is quoting me. I was actually speaking to the same thing I've been saying this afternoon and evening, in the sense that the design of the system is such that we can only respond to the problems.
Yeah.
There's no preventative. There's no effort to. We've not designed a system that is preventative. In medicine, prevention is better than cure. So we are mainly curative. And in fact, I'm going to extend it and say maybe psychiatry is no longer even curative. The prisons are becoming curative, because if you don't have mental health services, then you're going to have people with mental illnesses in correctional services.
Yes.
In fact, that's what we have. And then you're going to have the Minister of Justice complaining about the long waiting list of mentally ill people. In fact, if you have to go and investigate correctional services, they're probably spending a lot of money on psychiatric medications. Probably they are competing with psychiatric hospitals, because that's what that's what we then end up with. That's us being curative. If we were preventative, we will treat illnesses earlier. Let's take an easy example, or even before I go to that example, there's a joke I'm a person of jokes. There's a joke I usually say to my patients when they ask, my patients are mainly females, when they ask, doctor, how come we always we never find men waiting in a waiting area? And I tell them, no, they're at Stekfontein Hospital. Yeah. Which is true, because at Stekfontein, I'm just speaking on Stekfontein because I work here, because less females are at Stekfontein than men. And in my practice, you find more women than men, because the approach of men to mental illness, which we can talk about later as well, is different. So if you are not preventative, then a normal depression is going to end up being alcohol abuse. It's going to end up being a fight, domestic violence. It's going to end up with that man in prison. Or alternatively, a bipolar disorder that could be heavily managed will end up with cannabis abuse, will end up with psychosis, will end up being Stekfontein, and could end up at life as demony, as we did before.
Yeah. You mentioned, the different help-seeking behaviors and just approach by men, to issues of mental health. I read another article which was saying, the whole issue of what we call toxic masculinity, the way we are socialized as men, Men generally, it takes long for them to acknowledge that they are stressed. It takes long for them to acknowledge that they have a mental illness. And by acknowledging that, it's seen as a sign of weakness. And so they tend to delay. Let's talk about depression, for example. They tend to delay seeking help. So you'll find more females, going to your practice, but we'll find more males committing, complete suicide, as opposed to the females. Yeah. So, Doc, now let's get back then to another matter that affected South Africa: the issue of life testimony. You were called in as an expert witness there. You spent, I think, 2 days talking to the judge, asking you a lot of questions around life testimony. When you reflect on that life testimony tragedy, I don't want us to go into the details of it, but 144 of our compatriots died as a result of that project. And a few others, have still not been traced. And many were traumatized by that process, So what does it reflect to, as somebody who's in the heart of, mental health, services, as a professional in that space? When you look at that tragedy, which is 4 times what we saw at Marikana, what does it say to you? What does it reflect to us as a country?
Yes, Doc. The first one, when you listen when I went to give evidence, there was a debate at the beginning, which was resolved by Judge Mosenege, as to whether I was an expert witness or I was a litigant. Which the lawyers took issue with, because then if I'm a litigant, the judge should not weigh me as an expert witness. But yes. Judge Mosenege said I was an expert witness. And I would like to deal with that even here. Yes. I was at some level a litigant because we had taken the government to court over the issue of those patients, actually twice to court, except that then with that experience and having fought the provincial government for 2 years, then I end up now giving evidence as an expert. Yes. What it reflects to us, Judge Mosenege kept asking all of us there, what do we think was the reason for the province of Gauteng to want to close those life testimony facilities?
Chronic mental health care facilities.
There's never been a real answer from anyone as to what was behind that, and I'm not going to.
But they were saying they were implementing part of the policy of government that is pro deinstitutionalisation. That's what they were saying, which is a trend that they said is a global trend, to treat people more closer to communities than, to institutionalize them.
Yes, they were lying, and I can use that word without fear, because this institutionalization in South Africa, in Gauteng, let's talk about Gauteng, has started in 1994. Actually, I won't have the figures in front of me. A huge number of patients had already been institutionalized. There were even papers published about the process as early as 2005 about Gauteng institutionalization. So it cannot be that they were implementing this thing for the first time. It had already been implemented. A lot of people were already discharged, but we're left with about 2,000 patients in hospital who were impossible to discharge. That is what we're left with. Out of a population of about 12 million people, we're 2,000 people that we need to look after and accept that they are not dischargeable. So that was just an excuse as well. There must have been something more serious underlying this thing. The other thing, that if it was just a mere institutionalization, it should have just been done by us psychiatrists. It's our job to do it. It should not have been done by politicians and patients being picked up by barkies from life testimony and being dropped somewhere. Yes, We are not for institutionalization. I'm not encouraging people to stay in hospitals forever. It's not good for their quality of life. So what should have happened is that if there was a push for anyone to be discharged, we are the ones who should be doing that. And if we are not doing it, we must be asked why you are not doing it. So, and we must be questioned and even punished for not doing it. If we are so unethical that we're not okay, people in hospital, it shouldn't be that the MEC or the head of health must then now go to an institution and discharge patients. We must do it as psychiatrists. It's our job to do it.
Yes. Now, without going deeper, Doc, in that matter, there were recommendations that were made around that matter, by Judge Moseneke in his judgment. And part of that was that, there must be, a way to improve the services, the mental health care services. I've just forgotten the term that he used, and that should have been done by the department to showcase how they have done, that they've invested and done things differently. Do you perhaps have any idea whether that part of the recommendation was ever implemented? The other one was about a monument. That's not of interest to me today. More about, did we learn anything as Gauteng? Have we implemented that recommendation? And the rest of the country, because I believe that life as Esidimeni could have happened in any of the provinces in South Africa. Is there any learning by the country, from what happened at Esidimeni?
Yes, I'll phone but the savings. What if I want to get a job? I asked you, what if I want to get a job from Gauteng?
Do not like a politician. Answer like a politician.
No, I can't answer like a politician. I'm a doctor. I'm going to answer straightforward. In fact, it's more complex than just Judge Moseneke. There was a recommendation by the Health Ombudsman. And that recommendation said there must be arbitration, which is Judge Moseneke. It said there must be the Human Rights Commission must investigate, which is another recommendation. Out of Judge Moseneke and the Human Rights Commission, recommendations were made that must be implemented. The ones for the Human Rights Commission are even more interesting if you had to go and look at them. I won't remember them off my head, but because they've got deadlines for the government, for not only for Gauteng, for the provinces and for the National Department of Health to achieve this by this date and achieve this by this date. All of these recommendations, Moseneke, Human Rights Commission, and Health Ombudsman, they are coming after, in 2012 and 2013, the Minister of Health, Minister Motsoaledi, had called all of us in the country in the mental health space, and we came up with a policy framework that would guide us between 2013 and 2020 on how we should take mental health services forward so that we can realize these ideals that we're talking about today. I can take you back. That policy framework is now 2021 now, it's due for review. It has never been implemented at any level. I can say that without fear. It has never been 90% unimplemented. If there's anything, there could be something that has happened by chance, but 90% not implemented. The recommendations of the Human Rights Commission, most of them, the government, I'm not aware of the big ones. Maybe a small one that I won't pick up, but all the big ones, they have not been implemented. So, and the recommendations of Judge Moseneke, most of them, the big ones in Judge Moseneke have been implemented because they applied. Remember, with Judge Moseneke, they were specific to those patients. The payments, the recommendations that were specific to the life testimony patients, most of them have been implemented, except here and there, monument and that. But the recommendations that would improve mental health services in South Africa, those ones have not been implemented. The systemic ones, no, they have not been implemented. Yes, we are lagging behind. In fact, I'm still tempted, I'm still gathering energy, whether we should not ask the especially the Gauteng province, as the Mental Health Alliance, or to tell us on how far they've taken the Human Rights Commission reports, because they're deadlines, and deadlines have long passed.
Yes. So, Doc, if there were those kind of recommendations that were very specific, some systemic, some specific to the patients, or the families of those. If nothing much has happened, what more would make things to change? If that cannot make things to change.
I think it's the voters. It's the ordinary people. Civil society, yes. Things happen if the civil society, government has got many problems that they deal with, and not only government, actually, even private people, they've got many problems that they are dealing with, and we all tend to put mental health at the last thing that will sort out. No one is going to die anyway immediately. So at the back, so we put it at the back, so we don't do anything. And yet the cost to us, the cost of mental health, of mental illness to the country and to our own families and to our own selves is actually too huge to ignore. We should not be ignoring it at all. So not only, firstly, the financial cost, the emotional cost, the society. If you look at the what do you call it? How the community survives, how the community emotionally moves forward. If you don't have a good mental health care system, those things get affected. So I think as people like me, and the many people, families, we should go back to government and put pressure, because, not just another, because there's also, remember, there's also stigma.
Yes.
There's also, hey, why why should we pay for? Why should we pay for that? So people, not actively, not consciously saying that or thinking about that, but subconsciously, there's no
they've
militancy.
Already condemned. They've already condemned them.
Yes, yeah. So there's no militancy.
So why invest on people who are condemned in their their thinking?
Yes, and also these people won't complain anyway.
Yes.
Or even if they complain, we can ignore them.
But then we live in a country that's got a constitution, the one that is, everybody tells us how progressive our constitution is. And section 27, I think 1.1, whatever, it talks about access to quality health services for all. And that includes the vulnerable members of society. So they may not be, able to look after their affairs, but they are still humans who have got human rights that need to be, respected. And therefore, the resourcing should actually address that. Otherwise, that clause of access to quality services for all is just good in the constitution, but in reality, it's not there. And therefore, it needs to be enforced by civil society, I think, and other stakeholders, to say there is this group of people who may not always be in charge of their welfare. They are vulnerable members of society, and we need to make sure that they are catered for in line with the constitution.
It is not even a small number of people. We think, as I said, remember I said when we started, we cater for the severe ones who trouble us. The lifetime prevalence of mental illness in South Africa, 30%. So it's a huge number. It's a huge number of people who are at work. Yes, it's a huge number of people who are affected.
1 in 3
absolutely.
People in South Africa are likely to suffer from mental illness at some point in their lives. But then they also mentioned that 1 in 10 with mental illness have got challenges of accessing mental health care services.
Absolutely. So we're not talking about, yes. So we're not talking about a small number of people. We're probably talking about most people in most of our houses, but our families. But what happens is that when people are thinking about mental illness and budgeting for it, they don't think of it affecting themselves. I'll tell you, even the life testimony one, people were saying we're trying to move service to the communities, but you don't start by closing Stekfontein and life testimony. You improve services in the community,
Yes.
And the people who will walk to the community to those services, they will not need to go to Stekfontein. With
Yes.
time, you'll close to Stekfontein or Life Estimate will close by itself because you would have improved the services in the community. They will access the healthcare there. But when people are thinking about it, they think about how to save costs out of mental health care, which is
Yes.
stigma, not
Yes.
how to improve it within the same budget or even increase the budget.
Yes. Now, Doc, let's move on because you gave me only 1 hour, so I'm now, running out of time. But let's talk about the COVID-19 pandemic. What has been the impact of the COVID-19 pandemic to the burden of disease or to the patient load, in the area of psychiatry or mental health service?
Yes, when you look, I'm looking at it from a society's point of view now, and I'll look at different levels. Other disciplines like pediatrics, surgery, they had a decline in number of patients they had last year. In fact, those ones in private almost catastrophic because of the loss of income. With us, the numbers increased. I must also just declare my own anxieties. We all didn't know this illness with the lockdown, and it was the first time we're dealing with a pandemic of this nature.
Yeah.
And I initially thought, I don't think the COVID ward is for me. I'm not a physician, I'm a psychiatrist. So I'll avoid it. I won't have to wear the full PPE. Yeah. You'll be surprised. In the first week, when the physicians phoned me, I said, "Oh, give Ativan." Then I realized I'm actually burdening my physician colleagues.
Yes.
Our COVID ward, the patients are having anxiety, they are depressed, others are getting psychotic, others delirious, confused because of the illnesses. Yes, so that is what at the peak of the first wave, especially in Soweto, a lot of people were acutely ill, whether it's anxiety, but that makes it when they're there in the COVID ward itself, or psychosis or delirium. But what I've noticed now, after is patients who are coming to me and say, I had a COVID, I'm scared of getting another, I'm scared of the next wave, even though I survived the first wave. And then the literature has shown us, remember, it's the first wave, it's the first pandemic of this kind in South Africa. We've had HIV, but slightly different. But we look at the literature with the SARS-CoV-1, 2003, or even if you look at H1N1 or the MERS in other countries, there's post-traumatic, apart from the depression and anxieties that we get, people actually develop post-traumatic stress disorder as if they were in a war situation, if you understand post-traumatic stress disorder. So I think we're still gonna get even more. I'm seeing some of the patients even now.
We were in a war and with an invisible enemy.
Absolutely. Absolutely. So I'm actually getting patients now who are traumatized by the experience. And remember, HIV, which I thought through this, HIV was with us and was attacking us. Month after month. This one comes in waves. It's a real war. It comes in waves and it hits us. So people now, we're off the wave. They are waiting for the third wave, which is about to come. Those who got the illness are worried about the next wave. In addition to that, there's also the issue of bereavement, the deaths that we suffered, and how we suffer the deaths and how we buried the people who passed away. I mean, we were mentioning our colleague Lungile. We could not even go and bury him because you know that there's limitations, first of travel at the time, but also of the number of people in the allowed in the funeral, the restrictions. So it has affected us in many ways, and I think it's going to continue to affect us way beyond after the actual waves have passed.
Yes. I mentioned earlier that I work with employers, and what we have found in the past few months is that many are asking us to facilitate webinars, specifically focusing on the issue of loss and grief. They have found that there are many people who are struggling with loss, primary loss, as in the human, people who have died, or loss of function, post-COVID manifestations, where, others have got epilepsy, others have got memory issues and stuff, and also secondary loss, which is loss of the way of life, the way things were, and it's amazing how many people who are actually grieving the loss of what they consider to be normal life, not being able to go and work in the office, not being able to celebrate their wedding anniversaries, not being able to go to a graduation ceremony, and all of those kind of things. And
not being able to hug.
Exactly, not being able to hug, So, and some of the people who have not been able to, to navigate and manage this situation, some of them have gone on to have, mental illnesses, and therefore that would, to me, increase the workload to you guys. Yet, some of these could have been managed earlier if people were assisted to understand, loss and grief, and what are the things that they could do, and when to seek help before it becomes a complicated matter.
Yes, but on this one, I'm going to be fair to everyone. It's been a tough one. We didn't know about it. We didn't know how to manage it, and we've suffered different.
Yes,
multiple kinds. We've suffered multiple kinds of losses as individuals and as a country. I mean, even if you look at the health one, yes, hospitals get full, but no one anticipates that they can go to a hospital and be rejected because when they put a serious illness, because it's so full, and then later on they die. Can you imagine how the grief there? If you are the relative of that person, you're going to be angry at the doctors, angry at the hospital, angry at the system, and yet probably even the cause won't find in your favor because you are in a war situation. So people have suffered multiple losses. Of course, I know you have gained something because you've got now this channel, and before COVID, I did not want any Zoom or anything that is online. I would have said, I won't even know how to operate my computer. But out of the dark clouds, we got something, because now I give my lectures. In fact, it's made life a little bit easy. I get invited, especially at UKZN, to give lectures at times to the registrars. I no longer have to take a flight, sleep over, and then give the lecture at 2:00 and then fly back to Johannesburg. Now it's acceptable that we can actually do these things online. So whilst there's losses, obviously it was a war time, but I think after the war, like the First World War and the Second World War, especially the Second World War, probably will come out with a lot of other positives after after the suffering.
Yeah, Doc, pre-COVID, we were told that many people were stargazers. People could look into the future. We're telling us that by 2030, mental health challenges will be amongst the top 3 reasons for people to go and seek professional help. Now that was before COVID. Now COVID happened. I think COVID has brought that 2030 closer. Would you agree?
I haven't seen,
what are your thoughts about that?
Yes, I haven't seen the latest publications, whether people, the stargazers, have looked into it again, but I agree with you. My guesswork is that whatever was predicted before COVID, it's going to happen actually now, even earlier. I think it's going to happen even earlier, especially if you look at depression, post-traumatic stress disorder, anxiety disorders, substance abuse. I think it's going to happen much earlier.
Yes. Now, Doc, one of the things that came out through this COVID, or during this time of COVID, people were very angry that alcohol was stopped. They say COVID unearthed societal problems and things that were plastered, but now it seems as South Africa, we have a very unhealthy relationship with alcohol, and that being maybe some form of escapism from underlying issues. I haven't done a study on this, so please, colleagues of yours who are listening mustn't take me to task. It's a hypothesis in my head that many South Africans drown their sorrows. They don't deal, about males specifically, they don't deal with their issues. And so when alcohol was stopped and they had to face their partners at home and all of that without this thing that was helping them to escape, they all of a sudden found that, you know, there were issues. So what do you think about the relationship of substances and South Africans in relation to possible mental health?
Yes, I want to address it, but I want to address it outside the COVID, because COVID also complicated things. Being in my house, having to run around the swimming pool when I was used to running and going to the gym was something else. I could end up being problematic myself. But substance abuse and alcohol, especially amongst men. In fact, I'm gonna single out young men. To me, it is a problem because people are not addressing the issues that they have, the psychological issues that they have, and they use alcohol in particular and any other drugs to numb their emotions and to think that they'll just forget. By drinking alcohol, they'll forget. I always say alcohol is not a drink to be taken when you are feeling sad. Yeah. It's a party drink. You drink in a party, not when you are feeling sad. So, but we people, especially men, tend to use substances and alcohol in particular to almost numb their feelings. But what they don't realize, actually, we are worsening the situation, because firstly, alcohol itself causes depression, and also dealing with alcohol and its effect will also depress you even further, and it can also cause other mental illnesses. So I agree with you, they do that. And then it then happened at the time of COVID, then it just made things worse.
Yes. Doc, I'm going to ask you a last question, and I want you to think about it. I'm going to ask a colleague of mine who's my support staff to just read a few comments of the people who were, you know, but the question I'm asking you, if you were made, you know, this is a hypothetical question. If you were made, you know, or maybe the president calls you and says, I am worried about the state of mental health care services in South Africa, you know, and can you give me 5 things that if we can do these things as government, we could change the status quo? So I want you to think about it whilst my colleague just reads the comments.
Okay.
All right. So that's the last question that will come from me.
Yes.
You know, because I'm already over the time that you had granted me. All right. Nwamisa, can you please just read a few comments there?
Okay. Good afternoon, doctors. We have a couple of questions and comments. Okay, so the first comment is from Zizipo Nokwaza, which wrote, Dokotela, salute, and another one from Umtembeni Tebelele. He wrote, great and sweet guy, that one. I used to intern with him. And another one from Zamile Mankasha, which is interesting topic we are watching. And another comment from Untokozo Mzimela. Truly, prevention is better than cure. Thank you for that insight, Doc. And Loyiso Mbiko, very insightful topic, Doc. And then Bulelwa Makeke, interesting discussion. Now we wait for the inquest hearing starting on the 21st of June to establish if there is anyone who should be held criminally liable for the deaths. And then there are 3 comments from Nandile Kwabe. Mainstream media drove fear into the minds of the public. Then another comment, hence the increase of psychiatric related conditions such as anxiety. Another one from her, the other contributor is the inhibition of socialization. Human beings are wired to socialize. The last one, alcohol abuse is definitely a pandemic of its own. Alcohol is definitely used as an SSRI. So that's a comment from Nandile Kwabe. So those are the only ones we have. Thank you.
Thank you, Nwamisa.
So people are really listening here.
Yeah.
I thought I was just talking to you. I'm hearing cousins from Tabangulu. I'm hearing Dr. Tebelele in Port Elizabeth.
Yes, no. We've got people listening, Doc. And now, you know, there's a comment there from Bulelwa Makeke. She's actually with the National Prosecuting Authority. And just about 2 weeks ago, they issued, you know, a statement or a press release that from the 19th of July, they're going to be starting with with the inquest, where some people may be found to be criminally liable. So she is now saying the same thing here. So, you know, once we had the arbitration, which in some ways didn't go far enough to find people criminally liable. Anyway, it was not meant for that. So there is a process. So I just want your comment on the inquest, but also that last question about if you had to advise the president on how to improve matters of mental health care services in South Africa, what would be the 5 things that you would say if you do this as a country, then, you know, we will be able to deal better with the anticipated aftermath of COVID-19 over and above the high load that was already there of mental health, users in the country.
Yes. Please ask the listener or whoever from, I think said she's Miss Makeke,
Yes,
not to call me to the inquest. It's anxiety provoking to be talking to law people and having to be know what you're saying and be factual and not make errors. Otherwise, you could also be sued or charged for lying. No, we support the action, that's the inquest, actually. I think we should get to the bottom of it. I think for me, the politicians are important. And they must be held accountable. But I think the profession also needs to be held accountable. I think post-1994, which is a topic for another day that I have, there's been deprofessionalization of professions, where doctors will forget that they've got an oath to take, that they've taken. And also, it's not that if we tell the MEC the truth, we really will be out of a job. If you're a doctor, you can just go and run your practice if really they don't like your opinions. So I think the lessons that will be learned, that we have already learned there from the past activities of Lafes Demeni as the profession of medicine, and the lessons that we will learn out of the inquest will be good for us as a profession, so that in future, we carry on the baton from those who fought for accountability in Steve Biko's case, if you remember that one as well.
I remember, yes.
So I think we should take it forward. The other question you asked,
just before that, Doc. So the issue of, executive authority or politicians, instructing a healthcare professional who is an HOD to do things that are actually not right. So you're almost saying guys should stand their ground, and if they are forced, they've got alternatives.
Yes, absolutely. If us as doctors cannot stand our ground, what about the ordinary people? I'm sorry to be hard. What would be a primary school teacher? What would a primary school teacher do? She's a professional as well. A teacher should be able to stand their ground, but they should also learn from us, because us as doctors, we do have a few options that we could use in terms of income. So we should stand our ground and stand for our oath. So I'm not saying that you cannot do things. We should do things that are in keeping with what the government's vision is, but those things they should be within what parameters of our ethics, and they should we should not harm patients. We should not do things that will harm patients. Otherwise, how different are we to the doctors who did experiments under Hitler? So I think we should not. Or how different are we to doctors that treated Steve Biko? So I think we should keep within ethics. But I know you want me to take the whole 2 hours.
No.
So I'm going. So I'm going to address the president question. I'm going to address the president question. Firstly, if president phoned me, President Ramaphosa phoned me and said I must tell him what he could do that could be almost catalytic to change things, I would say, President, what's wrong with you? We've long diagnosed this thing. You've got documents documents in front of you that are telling you. But since you have not read the documents, I'm not going to treat you like a medical student or a psychiatrist registrar and say, go and read again. But your own documents, one of the key things that we need is that each province should have a mental health directorate. Gauteng has it, I think KZN has it, probably Western Cape has it, but not all provinces have it. I think there's a mental health directorate will be people who should really champion mental health within the province, because the implementing sphere of government is the provinces, it's not the national. So in each province, there must be a mental health directorate. And this directorate must not be just people who are just employed there to say what the MEC wants. No, this must be passionate people about mental health who are actually advocating for mental health even within the department, so that they can implement this thing. So that's one part. The second part is that I would ask, and it's not my idea as well. By the way, even the mental health directorate, it's not my idea. It's there in the books, in the policies of government. You must just implement it. The second one is budgeting that is targeted, because mental health is stigmatized. You cannot just say Eastern Cape must, sorry, I'm picking on my province. Eastern Cape must offer services, including mental health. I think there should be targeted budgeting for mental health, because if it's not targeted, it will be stigmatized. Linked to the budget, I think we should, because it's almost like I'm going to use a political word, there needs to be a revolution in terms of changing mental health. We need to convince the Minister Tito Mboweni that there should be some special fund to reverse the problems that have happened in mental health in the past. It's not a special fund forever, just to identify targeted issues within mental health and just reverse those ones. Last one linked to that is on the private sector. If we are still continuing with the current health system that we have, we need to revolutionize that PMB allocation, because, as I said earlier on when it started, it's very hospice-centric. So if we were to go to the Council for Medical Schemes, we should revise things. I know other specialists wouldn't like this, but for mental health should be afforded the primary health care. So I think the provinces should go and the Council for Medical Scheme should persuade the schemes, or should actually regulate the schemes such that they find outpatient care.
Yes. Because, like you said, the prescribed minimum benefits that are, forcing a certain healthcare, or diagnosis to be funded, they are not doing enough when it comes to issues of mental health care in terms of the benefit allocation. It still remains a poor cousin to physical health issues.
Absolutely. It's very, very hospice-centric. I'm not complaining. I get paid to look after the patients, but I think will reduce the pressure on me if some of the work was done by a psychiatry nurse in the community, as a general practitioner, or even so if it was at that level. Yes.
All right. Doc, those are three things, those statements, 5 things.
Oh, no, those ones will cover the other three. No, there's other things that we'll talk forever, but there's other things that can be done. But if you have to do those two, we'll go a long way.
Doc, I think good doctor, Unandile Kwabe, does Dr. Mvuyiso think there is a link between the cause of some mental health conditions and spirituality? That's the space and the interest kuyo nam lento ba iebet ke yokufunda somdala inzima, the issue of transcultural psychiatry. So you were a member of the Committee on African Psychiatry. Yes, so I'm sure you should be able to answer this one easily.
You said it was the last question. Yes, but I'll answer it. Yeah, the relationship is quite complicated between spirituality and mental illness. Yes, at a simple level, I would say there are spiritual issues and there's mental illness.
Yes.
And we focus on the mental illness, but you cannot exclude the overlap between the two. You cannot take it away, whether at illness presentation or at the time where you actually treat the illness. I mean,
Yes.
if you are depressed, you can still go and, in addition to psychotherapy and medication, you can still go and see your pastor, for instance, or your traditional healer, or whatever you do. So there's actually an overlap between the two.
Yes. Doc, I've taken so much of your time. Thank you very much. You know, it's a Saturday. We need to let our hair down. I know you don't have hair, but you need to relax and sometimes even take some mind-altering beverages, you know, without wanting something to answer to me. So thank you very much, Doc. And Yabulela, man, you know, you've given me almost an hour and a half of your time. I appreciate that. And you know, I'm sure people who are listening, they got a lot of, you know, insights from that has been gathered, you know, over this last 18 years of you being a psychiatrist. And, you know, they have been able to see that, you know, when it comes to issues of mental health, you are a real advocate for issues of mental health. So we will continue to look and see, Uba, you know, what are you doing to make things happen? But thank you very much. What you did at that arbitration to actually advocate for the vulnerable compatriots, it's something that I think we should all thank you for as the country. So thank you very much, Kikomkul.
Thank you. I did not anticipate that we'll run out of time. I'm surprised that it's already 22 minutes past 6. Thank you. Thanks a lot. Thanks a lot.
Right, thank
All
you
right,
very much. And
but
thank you to everybody who joined in to watch my conversation with Dr. Talatala. I hope in one way or the other, you were empowered by what we shared. And by the way, any one of us can be a mental health user. So this thing of stigmatizing mental health has to come to an end. I was once a mental health user at a certain point when I went through a certain life event that I could not handle. You know, any one of us, whether you're a doctor or anything, you know, any other profession, you can be a mental health user. So treat people the same way you would want to be treated. So with those words, I want to say thank you to all of you. Till next time.